The first concept I want to highlight is that when we talk about tumors in general or masses in the head and neck in the pediatric group or others, but in the pediatric group is a really wide range of different situations, as we may face cystic lesion or hamartomas, malformations, and benign tumors, a large number of benign tumors, and then we proceed to, unfortunately, very aggressive malignant tumors, so different histotypes. So this range is really very wide. So we are talking about different pathologies that are biologically, clinically different, and also our approach is totally different, and also the prognostic factors and the outcome. Altogether, these head and neck tumors account for about 15% of the childhood tumors, they say, and 12% of the malignancies. So they are not very rare in the pediatric population, but there are incidences around 2-3 cases per 100,000 persons per year, as you see in the slide. So this means 1/8, 1/9 of what we encounter in the adult population. So this means they are not frequent, they are rare, luckily. But if you mix these two aspects, altogether they are quite rare, but the single pathology is really very rare. So this justifies why we don't have so many evidences on their outcome, on the way to treat. So there is some uncertainty and disagreement on how to treat some of these patients. And it is difficult for the clinician to correctly address all the aspects. The spectrum of pathologies is not the same as in all the populations, so what we are probably more aware. As you see here in this slide, salivary gland tumors and nasopharynx lesions account for more than half of the cases. There are some differences in different ethnic groups, but other examples, like, for example, the oral cavity cancer is much less represented compared to the adults. And these tumors are slightly, their incidence is slightly growing during time. This paper I report here is very interesting. It is a comprehensive systematic review and is based on different systematic case collection from different geographic areas. And you see very briefly that lymphomas and sarcomas are the most representative lesions, malignant lesions in pediatric population. So one of the difficult aspects is diagnosis. Diagnosis in obtaining early diagnosis of the case, because usually there is not enough awareness of these type of lesion even from the pediatricians. And then to obtain the correct staging and description, the correct diagnosis from the, let's say, imaging point of view, but also from the histological point of view, there are some difficulties in many of these situations. There are some recommendation guidelines. We have to, let's say, raise a red flag when we see masses persisting for many weeks. Of course, the majority of the masses we may intercept in the children or teenagers are infections, basically. But when they are persisting for a few weeks, if they are larger than 2 centimeters, especially if they are painless, hard, fixed, as you see in this slide, they should be suspected for malignancy. And it is indicated that ultrasound investigation is the first line imaging for investigation, or the second line is MRI in case contrast enhanced CT, but MRI especially in the deep space located tumors or masses. And we have also recommendation from some committees, from the radiologists or oncologist committees, stressing the relevance of MRI for assessing this lesion, and also combined with CT when the pathologies encroach upon the skull base, especially, or in case angiography, if they are hypervascular tumors. But MRI is the second line effective imaging modalities. But MRI requires in the child specific protocols and specialized radiologists. So it is relevant to refer the case to a specialized center. These are probably the two most common malignant lesions we may encounter: rhabdomyosarcoma, nasopharyngeal carcinoma, is depicted in MRI. The interpretation and description of these lesions is very it's very technical and requires a very specialized radiologist for reducing the artifacts and optimize the quality. With regard to treatment modalities, of course, the range is totally different if we talk about benign lesions or malignant lesions. And the book you see here represented is a milestone of in this topic, and it's also interesting the review that is mentioned in the slide, which is quite recent. We don't have many systematic reviews, probably 8, 9, 10 systematic reviews on this subject available. Let's say that if we talk about malignant cases, usually a multimodal strategy is proposed and should be considered. As you see, surgical removal with or without chemoradiotherapy is very commonly used. Exclusive radiotherapy is, as a first line, is indicated in some lesion, in many nasopharyngeal carcinomas, and some aggressive sarcomas or neoplasmomas. In general, radiotherapy is very often considered in treating malignant lesions in the pediatric population, but the effect, we must consider that the biological cost of this treatment is much heavier than in the older population. With regard to xerostomia, caries, trismus, also voice changes, sometimes hearing losses also reported, and also about the impairment of development, or at least defects in development of the growing child or teenager, especially in early age. Other modalities, like, for example, adjuvant therapy, are also used, but we don't have it, at least as far as I know. We don't have specific protocols on this application in pediatric population. When we focus more on surgery, which is just part of the treatment, I want to stress this, the relative rarity of this lesion limits the surgeon expertise, but the surgical treatment requires specific anesthesiologists. And so these patients should be referred to a specialized multidisciplinary team because the surgeon, the surgical staff, the anesthesiologist staff must coordinate very carefully. And many specific aspects, the intubation, the measurement of the airways, the blood loss, circulatory support, many of these aspects are different or specific in the pediatric patients. Then the psychological impact, which is always all the time heavy, but in this type of patient is much more relevant. And so psychological support should be also given toward the patient and also the family. And then we have to specifically consider the interference of our surgery with growth potential of this child and the relevance of cosmetic rehabilitation, functional rehabilitation for the social development and psychological development of our patient. Consider this case is an example of late diagnosis. This is a 6-year-old child with a swelling in the cheek. It was considered odontogenic abscess of odontogenic origin. So it came to the correct diagnosis of embryonal rhabdomyosarcoma very late with a huge mass which was removed and apparently with safe margin, with clear margins. And this